Hey there, friends. Welcome to Lunchtime Live with the Center, where we talk about fertility topics and answer your questions too. My name is Ami Choksi. I'm your host. And September is PCOS Awareness Month. And Dr. Claudio Benediva, who is a lead physician and the medical director here at the Center for Advanced Reproductive Services, will be sharing his expertise. Now, over the years, welcome, Dr. Benediva, first of all.
Thank you, Ami.
Thank you.
My pleasure.
Now, over the years, you've seen many women diagnosed with PCOS here at the center. Can you talk a little bit about what PCOS is?
Sure. Yeah, I would say it's probably one of the most common problems that we see in our clinic and in general, and that is because it's one of the most common hormonal, disorders in women. The statistics say it affects 5 to 10% of women. So imagine that it's a very large percentage of women that have PCOS. So the name, PCOS stands for polycystic ovarian syndrome, and some people have criticized that name because it's a little bit of a scary name. Polycystic. Most patients imagine their ovaries filled with some huge number of cysts that they need to get rid of. And some people have even suggested to change the name. Maybe it should be changed. The problem is it's been used for so many years that we're all used to call it PCOS. Basically, it's a genetic disorder. Nobody has really found the exact reason, but it's really suspected to have an underlying genetic basis. And it's not just a fertility problem. It's more what we know today is that it's more of a metabolic disease. So women with PCOS have other issues. A lot of women have excess weight. They're overweight. They have obesity, and that's part of the problem. They have what's called insulin resistance. So their bodies are more resistant to the insulin. So they have to make more insulin to get their blood sugars under control, and sometimes they develop diabetes. One of the big issues with PCOS is the risk of developing diabetes over the years. So the fertility aspect is just one of the problems. The ones that, obviously the one that we deal the most, because patients that we see are interested in having babies, so we deal with their fertility aspects. But that's not the only one. Women with PCOS have irregular cycles. They also have sometimes excess hair growth, and they may have different issues that takes them to see the doctor.
And how is it diagnosed in the office?
Yeah, well, it's interesting because a lot of women get surprised sometimes. When I saw somebody this morning actually, and they never told me that I had PCOS, and it's really pretty simple to make the diagnosis because you don't need that much. You just need to get a little bit of a history of the patient, and ideally do an ultrasound, a transvaginal ultrasound, to look at the ovaries, because the criteria that is kind of universally accepted, the patient needs to have 2 out of 3 criteria, and these are being called the Rotterdam criteria, because there was a meeting in the city of Rotterdam where they came out with this criteria, and that's being sort of universally accepted as the definition to diagnose PCOS. So if you have 2 out of the 3, and 2 out of the 3, they're very easy to determine. One is irregular cycles. So women don't ovulate regularly every month. They get very irregular periods. So that just needs to keep a menstrual calendar, or just ask the patient, you get your period every month. So if you don't, so that's 1 out of the 3. The second one is also clinical, is any evidence of some excess androgen production. Any androgens are male hormones. So women with PCOS, a lot of the times, the ovaries will produce an excess of male hormones like testosterone. So that can cause excessive hair growth in the face or body, or acne. All right. So if the patient has excessive hair growth or acne, then you got number 2. And the third one is what's called polycystic ovaries on ultrasound. And again, this is not large, huge cysts, in the ovaries. They're actually tiny little fluid-filled sacs,
Mm.
less than a quarter of an inch, um, that are called follicles, and they're these fluid-filled sacs. Anything with fluid is a cyst, so that's why they call it polycystic. So these are just the eggs. So they're the immature eggs that are not getting released every month because the cycles are not regular. So they start accumulating in the ovary. So when you do an ultrasound, if you see more than 12 of those little follicles in the accumulating in the ovary, so that fits the ultrasound, definition. For the same reason, the ovaries are usually a little bit enlarged. So if they are large volume, more than 10 cubic centimeters, that's also part of the ultrasound definition. So if you do a vaginal ultrasound, you see more than 12 little, follicles, and those are the eggs. So that's why a lot of patients sometimes they ask me, "Can you get rid of the cysts?" I said, "No,
Mhm.
you don't want to get rid of the cysts because these are your eggs. What we want is to, release them so you ovulate and you can have a baby." Um, and if a patient has two out of the three, so that's according to this Rotterdam criteria, famous Rotterdam criteria. That's the definition of PCOS. So it will have the diagnosis made.
Okay. And how does PCOS impact fertility?
Well, the main way that affects fertility is by affecting the normal cycle, the normal ovulation. So, obviously, to get pregnant, you need to have an egg release, that's called ovulation, and that egg needs to be fertilized with sperm, make an embryo, implant, etc. So, the main issue, women with PCOS, because they don't have regular cycles, they don't have normal ovulation. Sometimes they don't ovulate at all.
Okay.
Sometimes they ovulate, but not in a regular basis, so they ovulate sporadically. And if you don't release an egg regularly, it would be hard to get pregnant. Not impossible, but you need you need an egg, you need sperm. So we have many different options to make that happen.
Okay. And does having PCOS mean that someone needs to go straight to IVF? How is it treated?
Actually, not. No, not at all. If I have to guess, I think that the majority of patients with PCOS that we see don't need IVF. I think it's a small percentage because
No.
the problem is with ovulation. If we can get the patient to ovulate by some other more simple treatments, then they will not need IVF. So uh, before IVF, there are many other treatment options. The one that is always recommended first is maybe not the easiest one to achieve, but is the number one in the list is lifestyle changes.
Mhm.
A large percentage of patients with PCOS are obese, they're overweight, and that kind of compounds the problem, increases that insulin resistance that I mentioned a few minutes ago. So if you lose weight, and according to the studies, women don't need to lose that much weight to get the benefit. Um, Even just 5% of weight loss is beneficial. So weight loss, exercise, increase physical activity could be enough to restore the regular cycles. We have for many years, very very wonderful oral medications, pills that
Mhm.
help women ovulate, and they work really well for patients with PCOS. The Probably the best well known is Clomid, or clomiphene citrate is the generic name, or Clomid. It's the most famous or popular fertility drug. Women take sometimes for other reasons, but very very helpful for PCOS, being used for many many years. And it's just one, just a pill that is taken for 5 days, and could be enough to help restore normal ovulation and help achieve a pregnancy. There is another pill that actually has become more and more popular, and more recently is considered the first choice even before Clomid. It's called letrozole, and it's taken in a similar way. 5 days, it's a cycle, and it works very well. Some of the studies show that it may even be a little better than Clomid. So both Clomid or letrozole are the most popular options for the initial treatment of PCOS. I mentioned the insulin resistance as part of this syndrome. There are medications to treat the insulin resistance. So if we determine that a patient has insulin resistance, and there are some easy blood tests to check for that, like the 2-hour glucose test, where they give the patient to drink some sugar, some glucose, and then check the blood sugar 1 and 2 hours later and see what happens. And if it goes up too high, it means that there's not enough insulin being made, and that makes the diagnosis. So these patients benefit from some diabetic drugs like metformin. So metformin is something that a lot of patients with PCOS have heard, or they have been treated with by their primary care or even their OBGYN, because it's so well known and so popular. It's used for people with diabetes, but because of the um, how close PCOS and diabetes are in many ways, metformin is helpful for women with PCOS that have that insulin resistance that I mentioned before. That is very common. So adding metformin, not probably by itself, but in addition to everything we discussed, the weight loss, exercise, letrozole, Clomid, and metformin, so all together help us to kind of fix this problem that is so common.
Okay. And you mentioned lifestyle factors impacting your fertility. Losing 5% of your weight loss could, losing 5% of weight could be helpful. Is there anything else that you'd like to add to that?
Well, yeah, the diet and increased physical activity, exercise. This is a metabolic disease, and the thing that sometimes women who have PCOS need to remember is that the story doesn't end when they get pregnant. I mean, that is obviously our goal, and we celebrate, when that happens. But because this is sort of a genetic disease, they're going to carry that all their lives. So in the future, they may, not be worried about the fertility because they already got pregnant, have children. But there'll be other issues like high blood pressure, hypertension, obesity, type 2 diabetes, increasing cardiovascular disease. All this metabolic component of the PCOS is just as important because it's long term. The pregnancy we can help, and then the rest of your life, these patients have to deal with all these health issues. So I think it's very, very important that they don't forget that, and they check for diabetes, and they stay on a healthy diet. And a healthy diet is a low carbohydrate diet, high protein maybe, but definitely low carbohydrates as if they had diabetes. Watch the blood pressure, watch the cholesterol, because that's for the rest of your life that you need to watch all these things.
Okay.
And increasing exercise and physical activity helps to lower the insulin resistance, so that definitely helps everything else.
Now, metabolic syndrome is one aspect that you talk about. Are there other types of PCOS that don't have that, or is that a key component of this?
Well, that's a very good question because, uh, yes, there are different types of PCOS. I've seen patients that are not obese, call them lean PCOS. I've seen patients that don't have any excess growth, and not everybody has the insulin resistance or the um, problems with their cholesterol or with their lipids. So there are cases of mild PCOS that only have just mild symptoms. So I think, if you remember those three Rotterdam criteria that I mentioned in the beginning, so you need to have two out of the three. They can any combination is possible. So
Okay.
there are patients that have irregular cycles and polycystic ovaries on ultrasound, but they don't have the excess testosterone,
Hmm.
hair growth, excess androgens. There are patients that have the excess androgens and the irregular cycles, but their ovaries don't look like they don't have PCOS ovaries. So if the two out of the three combinations could be exchangeable, and they define different types of problems, and I've seen a lot of patients that they have a mild case of PCOS, and maybe they are able to keep their weight in check, and they are active and they exercise a lot, so their PCOS is minimal.
Okay.
Doesn't affect their life. So that's the ideal, in my opinion. That's the ideal situation, that you can keep it in check with this lifestyle changes and improving your lifestyle.
And one last question. Well, if someone is diagnosed with PCS when they're younger, does that automatically mean that they may need some help getting pregnant down the road?
That's a difficult question, because it's hard to predict how things are going to evolve over the years in the future, and I think it's very likely. I think it's very likely that they may need some help, but as I said, it depends also on their lifestyle. Let's say they are adolescents and they're overweight and they start developing PCOS, then they change. They start getting very active in sports and lose weight, and maybe they will become mild case and have no issues when they try to get pregnant. Or, unfortunately, sometimes they progressively gain more and more and more weight, and the PCOS gets worse. Of course, they're going to need some extra help. So I don't think it's an automatic prediction that they're going to have fertility problems in the future. I think if they are able to modify their genetics, I mean, unfortunately, we're all born with different genetic makeup. So if you're aware that that's your genetics, and you're able to do everything that is going to help you to deal with it in a better way. So I think those adolescents that sometimes are diagnosed with PCOS can avoid a lot of the problems in the future, hopefully.
Okay. Um, is there anything else you'd like to share about PCOS that we haven't already?
Hmm. Um, I think there are several things that we didn't talk about, that we didn't cover, and one is that the treatment of PCOS, it really changes throughout the woman's life. It depends what they're looking for, what their main problem is, and I would say before, like an adolescent with PCOS or younger patients that are still not interested in getting pregnant, but they have some of the irregular cycles and maybe the excessive hair growth. So we will focus the treatment on that.
Okay.
Uh, Birth control pills is a very, very, very good option for women with PCOS. It does a lot of good things. It does lower the excessive hair, it helps with hair growth, it helps with the acne, it gives them regular cycles. So that's very helpful. Sometimes we add some medications if they have acne or hair growth to try to improve that. When they are interested in getting pregnant, we will obviously change the approach, and we will focus on helping them ovulate and helping them conceive. Later in life, let's say they already have children, they still have the PCOS. So we're going to focus more on the metabolic issues,
Okay.
right? We talk about the risk for diabetes, hypertension, heart disease, cholesterol. So all that needs to be taken care of. And uterine cancer is something may sound a little scary, but it is increased risk in women with PCOS, especially if they don't get periods and they don't take anything for that, and they go months and months without a period. There is an increased risk of developing uterine cancer, so that it's not a good idea to leave it untreated, and
Okay.
they should. It's pretty simple, like I said, with either birth control pills or any other medication to help bring the period every month or two. That will totally prevent it. So it's something not to forget sometimes.
Okay. Wonderful. Well, and let me just check the questions real quick. I don't see any new questions coming up. We have a lot of friendly thank you from my daughter. Thank you for all this information, doctor. So I want to also thank you for being here, Dr. Benediva, and thank you for joining us today. We'll see you next week at 12:30 for Lunchtime Live again. See you then.